Kristen indicated, I know it's me and lunch in about an hour in the expo hall, which I'm sure you guys are all excited to visit again. So hopefully we'll get through this session quickly, but not too quickly, because I do want to have it as interactive as possible. So let me start by introducing myself again. I'm Izabella Gieras, and I'm the director of, oh, thank you. I had it on, but didn't have it on. Again, did you guys hear me, or do you want me to repeat anything? Good. Okay. I know it's a smaller room, so I feel like I think the audio is pretty good. But again, my name is Izabella Gieras, and I'm the director of clinical technology at Huntington Hospital. But what you see here is actually Cedars-Sinai Health System. So this is actually pretty recent, and I didn't really have our marketing department, PR department doesn't have any marketing materials to put on in terms of logos because of the recent affiliation. Everything is still taking time. So I wanted to just let you know that Huntington Hospital and Cedars-Sinai Medical Center have affiliated. So we're part of the Cedars-Sinai Health System. There are other hospitals, if you know, the Southern California area by the LA that are part of that same system. Torrance, Marina Del Rey, and some of the other smaller entities. So what that means moving forward, we're still discovering what the impact is in terms of the affiliation. But one thing that has changed actually within the last month is that now I have an oversight of the clinical technology department, as we call our biomed department at Huntington Hospital, as well as the clinical engineering department, as we call it, at Cedars-Sinai Medical Center. So I do actually have some slides that talks through what the Huntington Hospital looks like staffing wise and so on, and then the same on the Cedars-Sinai. So I'll describe that briefly in the next few minutes. But it is a tremendous opportunity. I am looking forward to that. Huntington Hospital, it's been, it's a single hospital. I don't want to call it system. We're a single hospital. So having to join the health system is actually a wonderful news to everybody. And we look forward to, again, the opportunities that it brings, the affiliation from the clinical engineering or the HTM perspective, because we just talked about the nomenclature, and here we are, have clinical technology and clinical engineering. So we're working through that internally as well. So again, we're looking forward to standardization, looking at consistencies, simple things, even like policies and procedures from an equipment standpoint of view. I mean, the AEM stuff that we talked about, we do it differently at Huntington. Cedars-Sinai has a different approach. So I know many of you are part of health systems, so I know you've probably gone through those growing pains, but for me, it would be actually something new. So I might be even reaching out to some of you to learn about your experiences. So without further ado, cost-effective strategies and healthcare technology management. Sounds like a mouthful and sounds like a big topic, so hopefully I meet your expectations. But at the end of the day, it's actually what I'll be presenting, and I'm taking some extracts of a presentation that Roberto Torres, I want to give him some credit. He is the Associate Director at Cedars-Sinai Medical Center that we did a few months ago. So we've extracted some things, and he was not able to be here, but I want to make sure that his part of the presentation is incorporated in this. But just wanted to preface, some of that stuff seems very simple, what I'll be presenting, but sometimes, and what I've learned through the different presentations that I've attended so far and at previous conferences, if you can take one thing out of everything, I call it a success. Because if you take something that you feel that it's useful and applicable, and you take it back to your hospital and you're actually able to do something with it and learn from it and apply it, I feel, gosh, we at least did something positive, right? Everything else, yes, it may have been a refresher, you're already doing it, or you're doing it, but in a slightly different way, but the concept is already there. But if there is something, at least hopefully something that you take out that may be unique or different, or you're not doing it yet, that makes me happy. So let's see. Okay, it's working. So a little bit on the agenda in terms of what we'll cover today. So we'll talk about the summary, the healthcare environment, in terms of HTM and its position within the healthcare, mostly within the hospital setting, which some of you, I know we've talked about for those of you that attended some of the previous sessions in this room. I know that has been talked about. And then we'll dive into the perspectives between Huntington Hospital and Cedars-Sinai, and then end off with some of the best practices. So just a little bit before I get started about myself, I know some of you, but for those of you that do not know me, I have been in the HTM industry for over 20 years now, actually going on to I think 24 now. Started at UConn with the University of Connecticut biomed program. For those of you that may be familiar with it, Frank Painter, actually Carol Smith-Davis that just presented prior to me is the program manager for that UConn program right now. It's a 2-year master's degree in biomedical engineering with a 2-year internship at a selected hospital, which is wonderful. And a pitch for the UConn program in case you do have any prospective students that may be interested, or yourself may be taking that on. A lot of that work is done virtually now, obviously with everything that COVID brought on, so certainly a lot of opportunities to pursue that. After that, I went to the Beaumont Health System in Michigan. I spent almost 10 years there in clinical engineering. Started as a clinical engineer, ended up running the department, then joined Aramark at Mount Sinai Medical Center in New York City for a couple of years. And after that, in 2010, moved to Pasadena, California, and joined Huntington Hospital. So it's been a wonderful journey, a lot of great experiences, and have thoroughly enjoyed attending MD Expos and Amy, and have been very active with ACC, which has expanded my network. So pitch for some of the professional organizations, please do not wait, join. There are lots of opportunities there as well to share. So quickly about the session summary, it's pretty much everything that the title says, but in a more detailed version. So again, we're always being asked to do more with less, and we're always asking to show cost savings, cost savings, cost savings. If you want to do this, show me if you can save money somewhere else. A lot of it obviously has got to do with training. A lot of it has got to do with how we maintain our equipment, service contracts, and obviously equipment purchases, which hopefully many of you, if not today, hopefully this will be a further emphasis, because I know it cannot be emphasized enough. I know Al talked about that yesterday too, making sure that as HTM departments, we have a seat at the table when it comes to equipment procurement. So again, we'll talk about that and what that does in terms of, impact and support on our daily operations. And like I said, with, increased budget constraints, what can we do to be more creative, more strategic, but without impacting patient, obviously patient safety and patient care. So again, busy slide with lots of pictures, but one emphasis is obviously about the patient and the patient safety and the efficacy that I just mentioned. Obviously big dollar signs, because a lot of that costs money, whether it's again the equipment procurement, serviceability of the equipment, or you name it. We need to obviously come up with some sound strategies to be able to continue to support and also continue to support our existence, right? And increase our visibility within the healthcare setting. This is again just more of an emphasis, everything that you've heard, everything that we talked about. I know there was a question in the previous session, how many of our HTM departments report to IT? I think we had about a third of us raise our hands. I'll be actually curious to see what that is with this audience. Okay. So does the rest report to facilities still, or alike? Okay. Purchasing, because I know we've seen that supply chain. I've seen that before. Okay, all right, so it's still about half-half. I thought the trend by now would have been a little higher, but at least we have about 50-50. Okay. So these are some of the things that I want to cover today. I know some of the things that we talked about this morning is the AAM programs. We talked about standardization of CMMS language with the last session. I'm not going to be covering that, but things as cost savings related to sound initiatives related to that were brought up. So again, some of those are obviously soft costs. But eventually, whether it's through efficiencies or whatever that may be, or, reduction of waste, eventually do lead to some cost savings. Some of the things in particular that I would like to cover today are slightly different. We'll talk about the purchasing decisions. I mentioned the service contracts, parts, equipment, medical equipment procurement, And then some of these things, which again could be more on the soft side, but certainly could translate to some cost savings overall. And we'll talk about training, what I call springtime cleaning, which we'll go into some details, internship programs, and then employee management. Okay, so Huntington Hospital, I mentioned that I'll have a couple of slides on both Huntington and Cedars-Sinai. So I'm not going to read over this, but just on the high level, Huntington Hospital, we're licensed for about 619 beds. We have about just over 1,000, I think it's 1,500 assets at this point, operating rooms, the Da Vinci's, the usual stuff that everybody talks about. And then, like I said, in terms of our reporting structure, I do report on the Huntington site, since I do have a dual reporting structure now, to the it's CIO/executive director position, because some of those positions have also been updated as a result of the affiliation, but it's within the IT environment. And we have just over 120 individuals within the clinical technology and IT staff. My staff in particular, we have 11, and that includes myself, 7 technicians. We have what we call a project coordinator, just kind of my right hand, does a lot of support on the day-to-day operations, project coordination. I do have right now open position for a clinical systems engineer, so a pitch for that. I've actually had that position. That was quite a battle to try and get this going, but in 2017, I was able to get a clinical systems engineer for the first time in the Huntington Hospital history, so I was very proud of that, and one administrative assistant. So on the Cedars-Sinai side, other than being located in the very prestigious Beverly Hills location, I don't know if any of you have gone to that area, they're actually close to 1,000 beds. I feel like sometimes they lose track of the number of beds they have, especially during hot COVID. And what they did, they had a lot of what they called hallway patients, which were actually patients fully monitored. Actually, a lot of the data was even going to their Epic system, which was amazing how they had that set up in a relatively, obviously, short time due to the pandemic. And sometimes they were running at 1,200, 1,300 patients because of that. That, of course, was at the peak with everything that was going on with the pandemic. But they're pretty busy when it comes to, I would say, probably close to 1,000 beds at this point. 34 members, so a much bigger department, but very, again, very much involved in a lot of different medical equipment technology related activities. We do also have a biomed and a CE position open there. So again, just want to make sure everybody is aware of that in case there is some interest, or of somebody, please feel free to relay that. They also report to IT, which is called the Enterprise Information Systems Group, and there is over 400 of these individuals. So again, looking at the 120, 400, it's a much bigger entity, and their assets are over 30,000. So for us, obviously, it was a big change. Not necessarily a big change for me coming from Mount Sinai and Beaumont Health System, where we were in those numbers, but I did enjoy the luxury of being at Huntington Hospital, more of a community-based type of a hospital, but certainly, like I said, look forward to the opportunities that we have as part of the collaboration. So moving on, let's talk about Huntington and some of the purchasing decisions in terms of the contract. So a quick question, and again, feel free to ask questions or share your perspective on this as well. I think that would be good for the benefit of the group. How many of you are involved in service contract management to a level where you actually receive it, you manage it, your voice is heard? Okay. So the others that did not raise your hand, purchasing, individual departments that own these devices?
We're a larger system, so we have our clinical engineering corporate takes care of the contract.
Okay.
I have input into it if we want to sue one or end one,
okay.
But at the end of the day, it's going to fall to them.
But it's corporate within the clinical HTM.
Yeah,
okay, got it. Okay, perfect. So at least you guys are still involved in some level.
I work with the counties. I negotiated with AHS level. I
okay.
manage it, someone else makes the decision.
Okay, got it. So yeah, go ahead.
We can suggest this to our contract manager of what we want to have we do a work of that.
Okay, Good, good. Well, at least many of you, if not entirely under clinical engineering, have some involvement. So that's good. I'm glad to hear that, because sometimes, you know, it's done at a purchasing level or the department level, and clinical engineer or HTM does not have much of a voice. So some of the things that we have implemented, because and speaking specifically with the Huntington experience, we have a very much of an oversight of the service contracts. Anything medical equipment related would come through clinical technology department. We then work with the end users. We work with purchasing. At the end of the day, obviously, purchasing does assist with, you know, negotiations, you know, issuing the PO and all that other good stuff. But when it comes to, you know, setting the service, you know, levels for the agreement, deciding whether we want to continue with the full service, look into potential some, you know, creative partnership contracts or PM only, or eliminate the contract based on, again, the type of training that you want to do with your technical staff. But what we have created to make things easier for us is a checklist for assessing service contracts, because, you know, every time we kind of ask ourselves, what are the questions we should be asking the vendors, or what are the different things that we want to check off as we go through that assessment. So we just decided to do something quick, and that way it's consistent from contract to contract assessment. What we have done probably more recently, and I don't know how many of you tap into the services, or how many of you are even part of ECRI. So a minority. It's a subscription at a cost, which is not getting any cheaper, unfortunately. But if you are able to do, especially as a system, health system, they're a very good resource, and we've actually tapped into them, not just for what you have probably seen is equipment or equipment selection RFPs, but also service RFPs. We have recently actually run one through them on scope and instrument repair services. So we're going through that currently. But I know some of the GPOs, and we're with Vizian right now, also offer similar services, and some of them are embedded within the GPO services that you already subscribe to and pay for, sometimes maybe not known. So please do work with your purchasing department to make sure that they provide that access to you, because that is a valuable resource that we also tap into from time to time, but we felt that ECRI still has superior ability to assess, and they're more in tune with the HTM business. Like I said, partnership with purchasing and end users, we have weekly meetings with our purchasing department to review contracts as well as equipment purchases. Some of the things that we're doing now, and that has worked well even when Huntington was just one hospital, but what we're seeing more so is the master agreements. And with those, please do pay attention to things like you know, training and coverage, because one of the things that we have realized more and more so now that we're looking at it more from a system perspective is that you really want to get that training for free. I mean, don't just get it at the discounted rate or whatever that rate may be. It should really be included at no cost. And that's a big thing also now that I've learned with Cedars-Sinai. They kind of have that same mentality from a purchasing perspective, because the person that I work with in purchasing actually has biomed background. So it's a plus, because they kind of understand what we're looking for and kind of speak the same lingo, but is now on the procurement side. In-house and partnership contracts. I don't know how many of you have done these, but I have established one when I came in, a couple of years after I came in at Huntington with our ultrasound vendor. What I noticed that we have full service contracts, no ability to train. So when we were at a point where we could renegotiate, we decided to come up with a partnership agreement, in-house partnership agreement. I think it's what it's called, where well, now we're a little further into the different steps of that contract, but what we did was did the training, kind of like that master agreement that I spoke about. As long as we did the training with the OEM, then we were able to cut out pretty much a lot of the vendor dependency. We've narrowed down to us doing the PMs, us doing the first response. We were still purchasing parts from the vendor, but only requested them or their labor as needed after we did obviously all our due diligence. So that has tremendously reduced our contract. And we have tried to do that with some of the other vendors. Some are a little harder to get into that type of a partnership agreement. Others were more, again, open to partnering with us on that. We have and continue to partner with third parties. ECRI to some extent, for those of you that do have it and or don't know about it or have it available but have not been able to use it yet, they do have some options for third-party assessments. So if you do tap into them and ask them for some analysis, it's not just the OEMs, but they do have, especially if they have previous subscribers, provide that information. They already have that in their database. So some of it may depend on the region, because some of the third parties obviously may vary by region. But if you didn't know about it, please ask about it, because their database has expanded. And then what we tried, we have not implemented, but at one time we looked at it, the insurance risk-based approach. I cannot tell you which vendors do that now or which companies do that, but at one time with purchasing, we wanted to partner with a couple of vendors, or looked at a couple of vendors at that time to basically do a risk-based insurance program where we would insure basically our equipment for service with one vendor, and will be a certain number that we would insure for. And anytime we would have a repair respective of the vendor, we would kind of tap into that bucket for that risk-based insurance. Like I said, we did not implement that, but I know some hospitals have looked at something similar. Has anybody looked at anything like that or no? Okay. Yeah, and you've implemented that, Al?
Yeah, in my past, it was sort of a step toward self insurance.
Yes.
Right? But
Yeah.
it's hard for a small system to do that.
Mm-hmm.
But if you have people on a large system, you can share that risk across your entire
Correct.
self-insure. But for us, during that period of time, it was a good stepping stone to save money.
Yeah, exactly. So again, we looked at it. Looks like Al has some experience. Again, another option if you're able to look into that. So parts, again, probably preaching to the choir in terms of what you guys do already, but just more of a re-emphasis in terms of the things that we always want to make sure that we look at, and there's obviously always more. But when we put strategic contracts in place, we want to make sure that we also look at it from the parts perspective. Sometimes even consumables, right? I mean, depends what what equipment this is being tied to. Bulk discounting for frequently used parts. I know going through the expo and some of the vendors that we have already interacted with prior to coming today, there are different type of agreements. Some of them obviously have a commitment, whether it's a 1 year, 3 year, or 2 year or 3 year commitment. But if you have, based on your history, know that you have a certain spend, don't continue to do it on, kind of a time and material basis, but do formalize that agreement, because that could certainly give you, even if it's a 5 or 10% on an annual basis, it's, it's still something that you can write down as your cost savings. Shop around, but validate. We have shopped around and looked for different parts from third-party companies, because obviously we do have some older equipment, and some of that older equipment sourcing parts may not be as easy through the OEM. But what we have noticed, and this was actually particular with our battery trays, for those of you that use MX40s, teleboxes from Philips, we purchased from a third party, but after we got it, I said, let's validate to make sure that it actually resembles the OEM specs. And actually we run into some issues. So yes, it was cheaper, but obviously don't just assume and buy in bulk. I always ask my guys, if we're trying to explore something new, maybe buy a couple of them, test it out and make sure that it does meet all the quality and regulatory specs. Par levels were feasible. Obviously, we sometimes stock on quite a few things, especially if we know that we're using it or will be using it frequently, especially cables. Our SpO2 cables, patient cables for our patient monitoring, or our SpO2. We have, I want to say a pretty nice par level, probably a little bit more than what we should, but we've stocked up for quite a bit, and those fortunately don't have much of a shelf life, so it will last us for a little bit of time. The one specific thing, which I don't have it on here, but from our experience, and I don't know if any of you have been able to do that, but from a cable perspective, especially with our pulse oximetry vendor, what we were able to write into the agreement, it's a pretty lengthy agreement. It was 5 years, now it's 7 years. But what we were able to negotiate as part of that agreement from a consumable perspective is actually get a certain amount of dollars, and it's not even dollars based on, if you're recycling cables or your sensors or anything like that. It's actually based on spend, a certain percentage of our spend over the the duration of the contract was what we called kind of free money, TBD, or to be determined money, because at that point when you establish the contract, you don't know what that money is going to be used for, but it has certain criteria and the type of things that we can buy throughout the first 2 years of the contract. And one of the things that we were able to buy through those TBD dollars was cables. So that's why we stocked up on quite a few of those. And that was, again, part of the agreement that we have established early on with our pulse oximetry vendor. The other thing, I don't know if any of you have ever negotiated that, but what we did, I don't want to say it's creative, but in some way it is, but only because I've done it before in my previous institution. As part of our pulse oximetry agreement, we were actually able to strike a deal with that vendor for our patient monitoring equipment. So in our PACU and surgery patient monitors that we'll be replacing next year were built into the pulse oximetry consumable agreement. So yes, did that make that contract longer or more expensive? Not more expensive on consumables, but that's when it changed it from 5 to 7 years. So we had to make a commitment for a much longer period of time. I had to get it approved through compliance because we normally don't do 7-year contracts. But what it did give us is basically allow us to have that vendor work directly with our patient monitoring vendor and purchase that equipment on our behalf. So it's just another, I guess you can say, creative way of bringing in capital equipment if your traditional routine capital budget does not allow that. So just think of it from those terms as well. That was related to pulse oximetry. It was an easy sell because the patient monitoring equipment uses that pulse oximetry technology, but again, something that could be applied to other agreements as well. Just-in-time inventory, I know probably many of us do that, which is good because we don't want to overstock. I did talk about the cables. We probably did overstock a little bit, but it's kind of a fine balance. You have the money available, you need to spend it, otherwise you lose it. So we stock up on things that obviously don't necessarily expire, but we know that over time we're going to use anyways. But like I said, assess shelf life. Some items are not applicable to that and do expire, especially your batteries, which recently when we did our springtime cleaning, which will actually more like wintertime cleaning, which we'll talk about in a second, we did unfortunately find some batteries that, at one time we bought, shoved it somewhere in the corner, and now we're throwing them out. So do please pay attention to that because not everything lasts forever, unfortunately. Okay, so medical equipment, I know some of the things we talked about and some of that was also covered in previous sessions for those of you that have attended. Again, would love to know how many of you are part of the equipment procurement process, sit on the capital committee. Okay, so a few. Is that also at a corporate level?
Not necessarily, but I have to sign off on at my site for what they want to buy.
Okay. So I know different institutions have different ways of doing it. I think at the end of the day, it's more, are we involved from an HTM perspective? Hopefully in some way or another, hopefully sometimes at a higher level, but at least if we have some voice in the decision-making, because that's kind of a trickle effect. What we buy, obviously we need to service at the end of the day. So it's important for us to know what we're buying and are part of that process early on. So we can decide if we're going to do service contracts. Are we going to be doing some other partnership form of a contract, or do we take it in and at that point do we negotiate training, or do we budget for training if the training cannot be negotiated? So again, kind of a similar process to what we did with the service contracts. We do also have a checklist for that. We do tap into ECRI, but again, you can use your GPO, MD by line. There are various other sources that have obviously resources available. One of the big things that we're paying more and more attention to, and a lot of that is coming from the leadership, obviously rightfully so, is your return on investment, right? So we're not just buying stuff just for the heck of it. I know we often get requests from physicians, which I'm sure many of you have heard that they went to a conference or they heard something or the vendor stopped by, which I know that's been actually a blessing now with COVID because we have closed our doors to a lot of our vendors, but they still have ways of reaching those physicians, right? And they hear something, oh, this is the latest, the greatest technology, and they want it. So we have implemented a more stringent process now to actually show your, what is the value-based analysis before we actually bring that equipment in, or before we even start budgeting for that equipment. Obviously, partnerships with various healthcare stakeholders. Obviously, if it's something for respiratory or pharmacy or for surgery, we want to make sure that they're involved. And there's obviously a very comprehensive process for that, which is not necessarily part of this presentation, but I hope many of you, for those of you that are involved in the process, have the ability to also be part of, whether it's a request for proposal or a request for information, something that at least allows you to gather information on different vendors available on the market that provide that technology that you're looking for, because that's a great opportunity to be able to, again, learn about the technology, provide input, and hopefully make the right decision for the specific needs. Some of the other things that we sometimes forget, and again, if you're down to looking at the negotiations and kind of have a seat at the table, training, testing equipment. That's another thing that we've negotiated for as part of actually equipment purchases that we sometimes forget. But if we do feel that obviously we're going to take on the training, take on the service of the equipment, often there is a unique testing equipment that is needed for that. We did that when we purchased heart-lung bypass machines. We bundled everything together. We knew that we wanted early on to do training because we wanted to take it in-house, and there was obviously a lot of expensive testing equipment that was needed for that, rightfully so. So we've bundled everything together and got a pretty good deal upfront, as opposed to try and piecemeal everything and then pay for it later. Extended warranties, and another big thing, PMs during warranty. Sometimes, when we, well, I don't want to say that we're always involved. There may be one or two things that slip through the cracks, but one of the things that we do emphasize is make sure that where feasible, some vendors will just tell you right out, I'm not including that. You have to pay for it separately or put it on a contract after the warranty is done. But try and negotiate for PMs during the warranty or right before the warranty obviously is up. If you have a 1-year warranty, extended warranties are wonderful, not always easy to negotiate for, but sometimes, if you don't ask, you will never know, right? So at least it's something that should be part of your questions to the vendor. And the other piece, which I know Al talked about very nicely yesterday, is your replacement roadmap. I know we talked about 5-year, 7-year, whatever that may be. I know sometimes for imaging equipment it may be different. Construction projects, especially if some of you are involved in construction renovation projects, that's very, very important. And there's a lot of stuff that obviously comes with that. I know yesterday we had a question about, if you spread your project over an extended period of time and you make arrangements with the vendor, the technology may change, obviously within reason. I mean, if it spreads over 5 years, 7 years, and we've had that happen to us, just because we had construction delays and then we had COVID, right? So that altogether extended everything even further. But we do have notations as part of our purchase orders that we want to make sure that if there is a newer technology that comes out during that time, within reason, we work together, but at least we're aware of it, and that point can make a decision, because sometimes that could lead to changes in your construction costs, because now that could lead to, in California, OSHPAT, right? So you've had your design drawings for this particular design, and then a newer version of it comes out, which changes that altogether. So your architectural fees may change as well. We actually went through that when we selected our lights and booms 7 years ago, but did not install till last year. So obviously, we knew something like that was going to happen. So we had to go through the painful process, because we were very adamant that we want to have the latest and greatest, because that sets the stage for the next 5-7 years, right? You don't want to implement something that's almost at the end of its useful life, and then you're stuck with it. And then 2 years later, they tell you, well, end of support, now you have to replace again, which in our case would not even be possible. So we did have to present it, and we did have to do a business case in terms of going with the latest model, but it did add cost to construction, OSHPAT, architectural cost, I mean, you name it, but for a good reason, as long as you can build, again, a good business case to do that. Okay, so I know you cannot see this, but again, if something that you're interested, please let me know afterwards. So this talks about the in-house leverage, but specifically about ROI models. And I asked my guys to complete this when they're looking, when I asked them, especially when it comes to the operating budget, show me something or present something to me that you feel that we can take in-house or minimize vendor dependency, and then write out a quick ROI with some steps that we have in here to follow in terms of, okay, if we do it in-house, what would that look like from a labor, parts, testing equipment, whatever that may be, and then as opposed to us continuing with the service contract or some form of a service contract and then continued vendor dependency. So that's been working pretty well. We have come up with some ideas, based on what we're doing today with vendors. What can we do to, again, minimize that cost? And some of it is also leveraging your in-house talent, right? I'm sure many of your technicians are coming to you and saying, oh, I want this training, I'm really good at it, I can do it. And they have, proven that they have at least attempted to do something and shown initiative that they're interested, or worked with the vendor when the vendor was coming in to do PMs, repairs, and so on. So we do have, like I said, a sample that we use for ROIs. Long-term training, it's kind of like that long-term planning, the roadmap for equipment replacement. You also want to do that for training, right? You don't want to just, okay, let's do this training just because, right? We want to have some type of a plan, especially when you have long-term equipment planning, which kind of almost goes hand in hand, and you have that 3-5 year plan, whatever that may be. Think about what that technology is going to look like and try and plan for that as well. And that could be also part of developing your technicians over a period of time. We've talked about bundling, obviously, the training with capital purchases, reassess throughout the year. So even though you may put a 3-year training matrix, you obviously want to still reassess every year. Is that technician that you were thinking about would be good for, for this type of training in 2 years' time? Maybe, their focus has changed, or maybe they have left, right? And then now you have a bigger issue to consider how to fill that gap. Which that should never be, anything that you have to do retrospectively. So again, try and make sure that you proactively have backup plans in case any of your primary, especially high-risk type of equipment individuals leave. The other thing that I don't know if any of you have done or not, but include training as part of service contracts. We have recently, actually we've been doing this, but we have recently been working on a renewal for our anesthesia gas machines, and we always include 2 spots. Those are 5-year contracts, so we kind of spread that out over the 5 years, but can use it anytime over the 5 years. Obviously there's some terms and conditions if anything happens, but we do have a service agreement on major PMs with our anesthesia gas machine vendor. We did the minor PMs and repairs, but because of the contract that I have, I was able to bundle it with training. So now that we're renewing again, I added 2 more spots for the next 5 years. Has anybody done that? Okay, great. It's a good way of hiding the cost, right? You have to be creative, right? So again, a few other things as part of in-house leverage: springtime cleaning, winter cleaning, whatever that summer cleaning. Please do that. I know that may not necessarily lead to cost savings per se, but it is something that helps you clean up the space, find sometimes things that you have been looking for that are still good. We actually just did that recently, and the good thing is now also with our affiliation with Cedars-Sinai, we found some stuff that we don't use, but they still have. So it's like, wow, okay, guess we're not getting rid of it per se. We can now repurpose it somewhere else, so they don't have to spend the money on repairing or purchasing refurbished equipment. Partner with a vendor. There are a couple of vendors, at least one. I think we have plenty in the audience, but that we partner with, and we've had some really good partnership. And they're actually coming, I believe, this week to pick up some equipment, since we did some, winter cleaning. Internship volunteer programs. How many of you are able to do that? Biomeds or for your clinical engineers? Yeah, I think that's another excellent source of, in some way, again, it's some cost savings or efficiencies or spreading the wealth across. And also, at the end of the day, seeing how those individuals perform, so they could be, potentially filling your open position that you may have in years to come. So again, some hidden cost savings or cost efficiencies as well. So this is, I know you cannot probably see it, but this was really more about employee management, which again, one of those softer costs, depending on how you manage things, could lead to better efficiencies or increased efficiencies, increased work or efficiency in a workflow, which again could turn into some savings within the department's operations. But what you see here, and it's kind of evolving for us because we have a smaller department at Huntington, we have different positions that we have divided our staff into, and And some of it was originally just kind of progressing. Sequentially, we were moving through that cycle. But what I have recently instituted through some surveys and kind of focusing on the individual technician's strength, I don't necessarily just move them, one after the other in a cycle. I kind of, spice it up, and whether they're happy or not, because some of them have brought this up. Oh, I don't know what I'm going to be doing next. I said, I'll let you know. Don't you worry. Next month you will be doing this. So we do provide that ahead of time. So everybody knows, what their positions are, whether they're on PMs or whether they're doing repairs or, some other things, special projects and so on. So a lot of that is, related to how we manage our workflows, accountability, and so on. Just realized, let's see, okay, let me speed up. Again, eye chart, so I know you cannot see it very well, but when I talked about cost savings, I know this is a manual process, at least at this point, but we do record all the cost savings, whether it's from repairs or we shopped around and we bought something cheaper or something, again, that we were able to be creative about sourcing, whether it's a repair that, we would have otherwise maybe spent more money with the vendor, but we were able to do in-house. All that gets recorded, and I present that, higher up to our leadership so they're aware of our contributions to the bottom line. So this is a spreadsheet that's work in progress. And again, I know you cannot see all the columns, but this is a spreadsheet that we started using with our purchasing department, because like I said, we meet with them on a weekly basis, and we're tracking all the negotiations, because some of the negotiations are joint negotiations. It's not just purchasing doing it, but we collaborate on it. So whether it's service contracts or capital equipment, we record everything into the spreadsheet now, and again, present that out to the leadership. So they don't think we're just meeting weekly and talking through whatever, but we're actually doing some good work. So just a few last things on the Huntington side. I'm sure you do that already when it comes to you're not able to locate equipment, and a lot of it is more about efficiencies that turn into some cost savings in terms of non-productive time. But we don't have an RTLS system today. Cedars is looking at one. Actually, they have purchased one, but we're in the process of looking at the deployment path for that. So we'll be able to compare, how that truly provides us the return on investment by having something in place by end of this year, I believe, beginning of next year is when it will be live on about 11,000 assets. So it's it's a good pool of equipment. But the things that we have done, gift cards, lunches, competition between teams, just to kind of, again, get this going, because we do continue to have that unable to locate equipment on a regular basis. So yeah, go ahead.
How do you, how exactly do you do those competitions? Like if somebody finds something and then somebody else finds it the next month, they get the prize? That could be, but where we look at it is your PM completion rate within the PM team. I mean, it's as simple as that. We look at the number of items that they were assigned, with their completion rate, how many of them are, true unable to locate, because you do have some that, they may have not gotten to. So I always want to make sure that we can distinguish between that and that we look at the data from our CMMS system. But yeah, you could definitely be creative in various ways. I mean, it could apply to the repairs as well, looking at your open work order list for the repairs that are assigned to individuals. Sometimes it's tricky, especially if you divvy up the work across, several individuals. So that part sometimes is tricky for me to actually be able to get some true numbers and truly have a competition, but more so on the PM side than anything else. Work allocations, again, when I first started, we had a lot of things, going to the senior technicians that probably would have been more applicable to the tech ones. So again, from that workflow, work order assignment, look at that to make sure that there is a good balance and reallocate, your seniors to something that's more, again, high risk equipment as long as they're trained on it. Shift adjustments, again, from savings perspective to avoid overtime, especially if they have to come in on the weekend or off hours. What we have done, we asked, okay, do you want to take a day off during the week? But, we need you here on a Saturday for a special project to, again, avoid some overtime, which is a big deal for us because that's being tracked on a monthly basis for us, and that gets reported up to the leadership, and we have to stay within a certain threshold. So we're trying to come up with ways to avoid it and, still have our staff be able to, work with us on that.
So on the Cedars-Sinai, I do have a few slides, which I think we're still doing good on time. Some of that stuff obviously is very similar. So I extracted only a few things that, that would actually add value that are different to what I've talked about. Things that we do as well, but I didn't talk about, but this was, Roberto, to credit to him and the slides that he has prepared. But, looking at the total cost of ownership, so obviously when you look at it, you don't just look at the acquisition cost. I know we talked about service, we talked about parts. Obviously things like, software upgrades, forklift upgrades, consumables. I think we've mentioned that before, but that's a big thing too. When we look at equipment, we now also look at the consumables, and if there is some type of an agreement that we have to put in place, we do that early on so we can lock in the pricing over, 3-year period or so. Again, standardization, that's going to be a big thing for us now, especially with, our 2 hospitals coming together. We talked a little bit about that too, but obviously always look at your, your team service capabilities. Sometimes my techs tell me, oh, I want to get trained on this, but I don't really know where they came up with that, because it's totally off the wall, and I would never send you to that training based on what you have done. But they come up with some interesting ideas. Bless their heart, I do encourage them to submit things, but at the end of the day, you also know best where your team's capabilities lie, so you can match that with what the needs are. But at the end of the day, you also want to match it with somebody that is interested in pursuing it. We never want to force something on somebody that we know that they're not going to enjoy what they're doing, which means that they're not going to be productive and give us the results that we need. And then we talked about the group purchasing organizations and the discounts that they offer. Oftentimes they provide like end of the year, end of quarter discounts. I don't know if many of you received that as part of your communication with purchasing or your GPO. I don't know if you're on that listserv or mailing list, but be aware of that, because that sometimes is helpful to know. Service contracts, again, some of the things we talked about. I don't know how many of you are into the point of sale service contracts. You guys get involved in that, right? At the purchase of the equipment, they always tell you, oh, you have limited time to make up your mind, even though I know the warranty is not over yet, but this is the best deal that we offer you. We do it sometimes when we feel that it's appropriate, but many times, and this is our purchasing philosophy as well, if they want to partner with us, they will offer that deal in 1 year as well, or whatever that may be when your warranty is over. So don't always get sucked into it, but sometimes, again, do your homework.
One of the things we do with that, if we decide to take this after warranty, that's what we'll pay.
Yes.
Right? We didn't lock ourselves into signing the agreement at sale.
Got it. Okay, so that's another one way of doing it. And if they really want you as a continued customer, they will work with you on options. So yeah, good point, Hal. Again, things we talked about, can it be supported in-house? So you always want to do your homework right up front. Multi-year discounts. I know we have a philosophy of 3-5-year contracts. I know I talked about the 7-year contract that needed special approval. I think on average, you usually don't want to go past that 3-5-year mark. But again, if you can lock in the pricing, and if it feels that this is the you're not going to be doing any changes to that equipment over those 5 years, more power to you, because you have the best pricing. You don't have to renew every year, which, as many of you can probably attest to, could be a painful experience. Plus, at that point, you will incur those, increases. So where feasible and it makes sense, please do ask about multi-year discounts. The small print, which, all those disclaimers everybody is aware of. And this is a good one that Roberta included, and I'm sure many of you do with the big players. Do, quarterly reviews, see how things are tracking cost-wise, service-wise, any complaints. Sometimes don't wait, obviously, until the next quarter to review, some, customer complaint. Obviously respond to that right away, but that's a good time, to manage that contract if you have, again, higher profile. I wouldn't do that with every single vendor, but we do that with some of our major vendors today. Parts, again, I think we've covered some of that in terms of, preferred vendor pricing, lock in into a multi-year agreement if there is something of that nature, stay current on the industry pricing, shop around, that stuff that we talked about. And again, from a service perspective, not just from an equipment perspective, you can do, these type of quarterly business reviews as well, especially if you're partnering with a third party. That shouldn't preclude you from being able to do it the same way. Again, I know you cannot see that, but this is Cedar's training and cross-training. They have a much bigger staff, obviously, so there are a lot more names and technologies that they have, but keep a good running list of all the training that you do. That's something recently we have refreshed because we didn't really have a very comprehensive list, and it's very helpful for me to actually do that now with, again, the Cedars affiliation. So they do something similar, but they also make note what's in here, which I know you cannot see, is the cross-training that they do within their teams. Yeah.
Before you go forward, at what stage do you check on the strategy for support? So, like, for example, at point of sale, if it's a new technology, is this where you look at, like, we ask questions, do you offer by training, do you have for PM only contract, do you sell products, do you offer supporting? So at what stage?
At what stage? We do it as we evaluate equipment. We actually have it. When you do an RFP, because I talked about it very briefly, because I know you can have a whole session just for that. But when you look at your RFP, we even go back to that stage. We ask all those questions, and we ask, the 3 vendors that we send the RFP to, exactly the same questions you're asking. So we get all that information as part of the RFP responses. So we assess everything. What do they offer? What contract service options do they offer? What testing equipment is required for this equipment if we were to take the training in-house? All those things we ask as part of the RFP. If we don't do an RFP, which we don't always do, depending again on the type of procurement we do, we just have a list of those questions that we would ask, but we always do it as part of our equipment evaluation or equipment procurement before we issue the PO for that piece of equipment. So yeah, do it early on. We're kind of at that point are anticipating what am I going to do and trying to get all the facts so it helps me make that decision for the 1 year or 2 years, depending on what warranty you're able to get with that vendor. Okay, yeah, good question. So again, another one that I may not necessarily see, but this is a Cedars kind of a career pathing. I know we talked about strategic progression, in terms of making sure that we look at the skill set and the staffing that we have, especially if we may have an aging staffing population within our department. We always kind of trying to anticipate, especially if there may be some that you feel like, oh, they may be leaving based on a personal family situation. You always want to try and anticipate that. The same with the career pathing, right? And I think we talked about actually at the leadership summit yesterday, that discussion that we had in terms of, okay, so we have a BMAT 1, but if that BMAT 1 turns out to be good, what is that career path for that individual, so we can continue to invest in the individual, that individual grows, and hopefully we can keep that individual. Because sometimes, and I think he has it, it's more here, actually, that there's a comment, I knew he put something in here. Holding on to well-trained staff is more effective than training a new one, right? So if you know that individual has potential and you want to continue to invest in them, it's kind of a win-win, right? I mean, if you can show that you're investing in the individual, you're supporting their professional growth, hopefully that will prevent them from going somewhere else, because then the hiring process, investing again in training in that individual, especially if they have some key training on some maybe critical high-risk equipment, I would say have that conversation with that individual, because the worst thing is to lose that individual and then you have to struggle. Yeah.
Would direct people toward Amy's succession planning guide that was published.
Yes.
Great.
Yeah, that's a good, yeah, thank you. Yeah, absolutely. And I know we don't do enough of that, and I know we're so busy with everything else, that's probably like the last thing that we want to be spending time on. Not that it's not important, it's just from a your day-to-day commitments, but it's so important, because again, you can struggle tremendously if you lose a key personnel.
How much do you emphasize and encourage the senior staff to start training conversion? Say, looking at possibilities.
Yeah.
Possibilities, and that sort of conversions. Yeah, these guys already are banned.
Yes,
There is dead time today,
yes,
but do you encourage this? Some of those other areas?
yeah. Yeah, no, that's a good point. We do actually, part of our senior, excuse me, senior tech job description is to mentor, others in the department. I mean, it may be a cross training with another senior technician, but specifically related to those, that are less senior than they are, to provide that knowledge. We do sometimes team them up, especially if one is trained on something. What we probably could do a better job of that. But what we have been doing in the past is teaming them up with other less senior individuals. For others that are lab, especially lab equipment for us, we do have about 2 key individuals that are trained on lab equipment, but what we have done over the last, I want to say 5-6 years, the newer staff that we have acquired, we have specifically put that as a goal in the annual evaluation for the senior tech, because it's the seniors that are the lab experts, to train the less senior individuals. So that was actually something that they had to do because it was part of their goals for the forthcoming year. So we do encourage that. The other thing that I want to actually start doing better, but we haven't really with COVID because there wasn't a lot of training, but in the past and moving forward, hopefully we can bring that back again. Whenever somebody went to training, that would have to do some type of a presentation or, some form of trying to at least educate others of what they learn. I'm not saying that they're, going to now become experts on that equipment, especially if you have some restrictions and, they get certified and they're the only ones that can obviously work on that equipment. But it's really more about the awareness and sharing that knowledge within the department, because we've had some, I don't want to say complaints, but comments from other staff. Well, this one goes to training, but never tells us anything about the training. What did they learn? Maybe even some tips, at least for like a first response or something that they can intelligently respond if they're on call, because we rotate our on call. So at least, something, like I say, if you take one thing out of the presentation, it's a success. Yeah.
I do say when they come back, and also train.
Yes, yeah, you can kind of test them. It's not just, did you pass your test? Yeah, but what did you actually learn? Put it to good practice. So where possible, and I know this cannot always happen, but we try and time the training, especially if there's a lot of training available, with like preventive maintenance schedule that we have. So if we train them on like the V60s, we did that, actually it was virtual training now, but I trained one of my techs on that, and it was a month or so before the V60s were due for PM. So I said, okay, well, you guys, you just got your training. You're the one that will be doing the PMs on this. Obviously, with the help of somebody that's already trained and have been doing the V60 before, but this is the perfect time. Yeah.
How do you get a technician brought in to things such as the environmental care committee or to the capital committee when they are a technician and not a manager?
Correct, yes. So good question. So for most part, the way we're structured, our technicians have, good or bad, they have limited exposure to that. So from an EOC perspective, yes, we bring them on rounds only as needed, because we have, and I think I mentioned that before, the clinical systems engineer and the project coordinator, they rotate the EOC rounds. Just an example on the EOC rounds. We try to engage them in some of the projects, like we have a project about new equipment evaluation, and we have trials, and then we have vendor presentations. If I know that that individual will either be trained on that equipment or already has similar training, because now this is a continuation of another respiratory type of equipment they already have, and I have already invested in respiratory equipment with them, I will engage them. But it's not something that I would say I do on a regular basis, because we have others in the department that do that on a day-to-day basis, like the EOC committee, the EOC rounds, and those kind of things. Incident investigations, they do get involved, because obviously they will get the equipment. I will work with them to, obviously troubleshoot and go through, the event and the description of what happened, so we can get to the root cause. And they provide me with a report for their findings, and then it would still be me though uploading it to the system that we have.
I was looking at how might you leverage the ability to keep that progression, to keep that visual.
Oh, as part of the career pathing and and sustainability. Yeah, no, that's a good point. I have not looked at it from that perspective, and I think a lot of it is, again, time and their prime. I don't want to say that, you know, that's all they should be doing is repairs and PMs, but, you know, at the end of the day, you kind of have to divvy up the work, right? Because at the end of the day, the work needs to be done, the PMs have to be completed, repairs have to be done. So I'm having them focus more on that, and where applicable, especially more on the senior side, where I would find that more applicable to them. The BMAT 1 and the BMAT 2 for me right at this point is the cross training, or sending them to training where that could give them progression to step into the next level. And then the other piece that we're not enforcing yet is the certification, the CBET certification, which I know we talked about yesterday as well for some of you that were there. Cedars actually has it as a requirement for BMAT 2 and up. Huntington, we haven't made that a requirement yet. I had some struggles with our HR to make it a requirement, but now that we're with Cedars, I may be able to go back to HR and say, hey, you know, let's kind of have that standard across the board so we don't have inconsistencies. So from that perspective, that's one big thing that I do encourage them is the certification. Again, I haven't been able to make it required, but we highly encourage, we pay for the exam, we pay for the study guides. I mean, we help to facilitate as much as possible. At the end of the day, it's still up to the individual to do the registration and actually do the exam and pass it successfully. Because we do pay for it, we reimburse for it if you pass it successfully. So that's the catch. We don't pay for it up front. We eventually pay for it, but you have to pass it. So, but yeah, no, good observations. Thank you. So I know we're pretty much out of time, but I appreciate all the questions. And let me just run through this quick. This is a pitch for the third parties because we would not be here without them, obviously. So when help is needed, and I know this was on the Cedars side, but we do tap into some temporary help as well. And there is some great contacts that I made on the exhibit floor already for additional support. But again, a lot of stuff that you're probably doing already in terms of supplementing and augmenting help. Somebody's in LOA or you have an open position. That's where the third parties come to us to help us through that open position period of time until we fill that position. I know Cedars is they call it the pump season because we have about 10,000 devices today on the Cedars side. So there's always help needed. So during the pump season, which ranges, I think, between January and April, we do get additional help. And again, kind of like what we talked about with, shopping around, establishing partnerships, sometimes long-term partnerships. We've done that on the Huntington side. When we need help, we actually have a long-term partnership with the vendor. The same thing, again, you can do with parties when third parties when help is needed. Pizza for rewarding, kind of similar to what we talked about, buying lunch. Another thing which you haven't invested, I know, again, this is on the Cedar side, 3D printing. Actually, on the Cedar side, it's found to be pretty successful. I actually looked at some of the parts that they were printing that are, obsolete equipment or just attachments or accessories, whatever that may be. Sometimes it's purely, for the satisfaction of the physician because they're looking at something specific and we're able to meet the need. So that has proven to be a good investment. And last but not least, best practices, but we've pretty much covered a lot of that already. Accountability is a big thing, but again, that could also be a session on its own in terms of, holding individuals to what they have been assigned, because obviously, everything has to follow a certain regimen at the end of the day, right? Otherwise, all those great ideas and everything that we talked about is not going to work. And then some other things, but the one thing that I like that he highlighted, keep track of and celebrate your successes. I think at the end of the day, you want to have fun, right? I mean, what you're doing needs to be something that you enjoy doing. Otherwise, forcing somebody to do something that they did not enjoy doing daily, or having, putting training on them because you feel like, okay, this individual is going to do well, but they're not really the best candidate. Those kind of things. Just make sure you know your people. Make sure that as you have some wins and successes, projects well completed or projects completed on time, PM completion rates. I know it's kind of like going like a broken record about all that stuff, but I feel like with my staff, when we do that, even just buying them a pizza or buying lunch with food that they enjoy, at least they're, you know, motivates them and it keeps them going. Okay, for maybe a week, and then you have to do something else again. But, you know, think about different strategies just to keep them going, especially with COVID and now kind of post-COVID. I know we're never going to be post-COVID, but, you know, as things start to slow down, that's a lot of things that, especially within Huntington, we've been emphasizing, not just to the biomed staff, but just in general, because everybody's been through so much. So just make sure you recognize that at the end of the day. I'm sure you all do already, but cannot say that enough. Thank you. I know we're past time and it's lunch and everybody's hungry.